In the previous lecture, we have seen on the basics of acute leukemia, where we have seen what are the features of acute leukemia and what are the differences between an acute myelogenous and acute lymphoid leukemia, and how to differentiate between a myeloid blast from a lymphoid blast. But in this section, we are going to discuss on the core principles of what an acute myelogenous leukemia is. You know, acute myelogenous leukemia means your like your blasts are going to be from the typically, which means your blasts are going to be in the blood and the bone marrow predominantly. We discussed this point innumerable times. And myelogenous means the blasts are going to be of myelogenous origin. That's it. So this is what you mean by acute myelogenous leukemia. At the same time, it's also important to understand certain classification systems for acute myeloid leukemia. That's one of the important system is what we refer to as something called French-American British system, otherwise referred to as FAB classification. So this FAB classification is based on predominantly on morphological appearances of how a blast looks like and certain cytochemistry analysis. But later on, the WHO came up with a new classification system which is even more important, that is based on cytogenetics. That's why I'm telling you, a future of hemato-oncology and any hematological malignancy is going to be on cytogenetics only. So currently even the WHO classification is the one that is preferred, and that is what is going to be the future as well. That's based on cytogenetics. Anyway, it's worth knowing about this FAB classification, which did a phenomenal job in telling you the different types of leukemia, which gave a very bird's eye insight on how the blast will look like. Anyways, let's go on to the FAB classification system. So in the FAB classification system, you have acute myelogenous leukemia being classified into 8 different types from M0 to M7. But where these cells originate from, that's a big question. So let us see the origin of these myeloid cells. Start with the hematopoietic stem cells, which becomes something called a common myeloid progenitor. This is called a common myeloid progenitor. And it also gives rise to a common lymphoid progenitor, you know that, but that's not important anyways. So let us concentrate on the myeloid progenitor now. This common myeloid progenitor, you know, it's going to be called as something called CFU-GMM. This is a common myeloid progenitor, colony forming unit GMM. So this common myeloid progenitor is going to give rise to 3 types of blasts. One is called a proper myeloblast. Second one is what we refer to as something called an erythroblast, and the third one we are going to call it as something called a megakaryoblast. This myeloblast itself has some early stages and late stages, which further differentiates into something called a colony forming unit, granulocyte, monocyte, or a granulocyte macrophage colony forming unit. This which further differentiates into something called a promyelocyte. Remember, since even though I tell the word simply promyelocyte, there is neutrophilic promyelocyte, there is eosinophilic promyelocyte, and you have even a basophilic promyelocyte also, even though the exact origin of where the basophil is coming from is a controversy. But anyways, so you have a promyelocyte and it gives rise to something called a monoblast. So this monoblast is going to form something called a monocyte. This is going to form something called a monocyte, and this promyelocyte is going to further differentiate into your neutrophils, eosinophils, and as I told you, the controversial basophils. So this is what it's been understood at the FAB classification system. So but anyways, even though the modern understanding is changing, and we know there are some changes in the origination system, which I have told you in the beginning of the hematology lectures. In stem cells and all these lectures, I have given a very good idea about what is the current system of origin of all these cells. But anyways, this is the thing that has been understood at the time of your FAB classification system. But anyways, let us see. So the first one, if the blast origin is coming from the common myeloid progenitor, this is what we refer to as something called AML, M0, or I can tell this is nothing but completely undifferentiated, or I can even tell there is no maturation. It's a myeloid blast, but there is absolutely no maturation into any particular lineage. So this is what I'm going to call it as something called AML without maturation. That's the correct name, or undifferentiated AML. I mean, you might ask me like the word undifferentiated is wrong. That's why I told you AML without maturation is the right thing, because blast itself means they are not differentiating into a particular lineage. That's why completely undifferentiated is a wrong name. Instead, you can call it as AML without maturation. So then if it's a myeloblast, if the blast is originating from the myeloblast, and if it's typically originating from the early myeloblast, we are going to call it as AML with minimal maturation. Minimal maturation. That's what we are going to call it as AML M1. So if it's going to originate from the late myeloblast, we are going to call it as AML M2, or we can just call it as AML with a good granulocytic maturation. So AML with a good granulocytic maturation. So this is called AML M2. If it's originating from the promyelocyte, we are going to call this as something called AML M3, otherwise referred to as acute promyelocytic leukemia, or APL or APML. If it's going to originate from common granulocyte monocyte precursor or colony forming units GM, this is what we refer to as AML M4, otherwise called as myelomonocytic leukemia. Myelomonocytic leukemia, because it's going to have both granulocytic as well as your monocytic maturation. So if it's going to originate from the monoblast, we are going to call it as AML M5, AML M5, clear? So which is nothing but a monoblastic or monocytic leukemia. So it's typically predominantly they have monocytic differentiation. If you have this one, blast originating from the erythroblast lineage, so we are going to call it as AML M6 or erythroblastic leukemia. On the other hand, if you have from the megakaryoblast, this is supposed to be called as something called AML M7 or acute megakaryoblast leukemia. So these are the different areas of where you see the AML predominantly. But remember, if you take your staining wise, that's what is very important. If you take your typical staining of your AML blast, so let us put the myeloperoxidase stain, number one, that's MPO, which is classically, whenever it's positive, it goes towards your myeloid blast origin, which we have discussed already. Then you have something called Sudan black stain, then you have your PAS, then you have your non-specific esterase stain, then probably I can put something called oil rods. So these are things that I'm going to tell, because these three things, if you see them, 100% you can tell it's myeloid blast only. But PAS and NSC can be seen sometimes in myeloid as well as lymphoid blast, but if you see MPO, SBB or oil rods, it is equal to blast of myeloid origin. That's it. Very, very standard point. Number one, if you ask M0, they don't stain at all. They don't stain for anything. Even the oil rods will be negative. But how can you tell it's myeloid blast then? Obviously, you are going to tell only by using something called CD markers. So CD markers will be suggesting that the blast is of myeloid origin. So CD markers will be positive, that CD13, 33 will be positive. This is going to be positive in all the AML blasts. So with this only you can identify that it is actually having a myeloid differentiation rather than having a lymphoid differentiation. But you do not see any stains getting positive, or because it's completely no maturation into any lineage. So it's a myeloid progenitor only. It's just a undifferentiated myeloid blast. So that's going not to stain with anything, but only evidence of a myeloid blast being the CD markers. That's what M0. In M1, you are going to stain, yes, positively for all this. Oil rods may be minimally positive. Again, CD markers will be there, and if you take M2, myeloperoxidase will become a little more strongly positive. Again, PAS and NSC negative, and your oil rods will become a little more intense. And if you take in M3, this is going to have the strongest MPO and SBB positivity, and highest number of oil rods you will see in M3 only, that is acute promyelocytic leukemia, and it has its own translocations and CD markers, which we will discuss in some time. And if you take your M4, again the intensity of staining will reduce, and the amount of oil rods is going to reduce, number of oil rods, but still you might see, but they become more staining for your non-specific esterase, but still PAS is negative. You don't stain with PAS. Then if you take M5, in M5 your myeloperoxidase will be completely negative and Sudan black will be negative, and you are not going to see any iron rods because it is completely monocytic differentiation here. It's not going to have any granulocytic pathway at all. So it's not going to have any maturation through this. So all these three are negative and PAS is still negative, but you're going to have maximum intensity of staining with your like non-specific esterase. And when you go to your M6, your this thing will be negative, your MPO will be negative, you might, and again Sudan black will be negative. Typical erythroblasts do not stain for Sudan black, iron rods will not be seen, and non-specific esterase will be negative, but they will be strongly positive for PAS. This is like fine blocks, fine block positivity. Clear? Then if you take M7, once again MPO and Sudan black will be negative, and PAS will be negative. PAS is actually variable. We not write PAS will be negative, PAS will be variable, non-specific esterase negative, and we don't see any iron rods. So these are the different staining process where you can see the iron rods and Sudan black and MPO positivity is M1, M2, M3, M4. These are the places where you are going to see this MPO positivity, Sudan black positivity, and iron rod positivity typically. And where you are going to see this non-specific esterase positivity is in M4 and M5. That's where you are going to see this non-specific esterase positivity. And where you are going to see this PAS positivity is on M6 and maybe in M7 to an extent, but it's variable, highly variable. But PAS positivity always means M6. Non-specific esterase positivity means M4 and M5, and your MPO, SBB, and iron rods positivity is based on the first four, the M1 to M4. Apart from that, they themselves have a lot of cytogenetic markers and other features, morphological features, which are not going to discuss. But this particular table will give you a very, very good idea about how to consider about the myeloid blast and the origin of different myelogenous blasts. So this is the basis of what you know is called the FAB classification. To understand the FAB classification better, let us move on to the images, which is really important. So first let me tell you how you're going to see the MPO positivity and how SBB positivity looks like. This is how it looks like, and you can also see an iron rod here along with the myeloperoxidase. Remember, iron rods also do stain positively for myeloperoxidase and Sudan black. So this is one example of an iron rod, and you can clearly see this is how MPO and SBB staining looks like. And this is, if you see any kind of positive myeloperoxidase or Sudan black, I can tell this blast is from myeloid lineage, even though the relative percentage of how many blasts are going to stain and all these things are there, but still this is equal to myeloid blast. That's it. Clear? Fine. So let us go to the AML M0, number one. So AML M0, that FAB M0 means it is no differentiation, or you can tell without maturation. Acute myeloid leukemia without maturation. So what you are going to see here, these are huge blasts, these are large blasts, and typically they don't have any differentiation, means they will be completely agranular blasts with an extremely large nucleus. Large agranular blasts with high mitotic figures, extremely big nucleus, and a very small cytoplasm, and whatever the cytoplasm is, they are completely agranular. You can see here they are completely large and agranular blasts. Clear? So that's what you're going to see. And can you ever see any iron rods? I don't think so. There is no iron rods in cytoplasm whatsoever. You can't see any iron rods. And I told you the staining process, I can write the staining over here. You know that this is MPO negative, PAS negative, and Sudan black negative, and non-specific esterase negative. Definitely it's not going to stain for anything else. Is there any prominent cytogenetic figures that these patients will have? No, absolutely not. Cytogenetics also is not there. Any typical cytogenetics to tell about this? No, not at all. No recurrent cytogenic abnormalities for this AML M0 as well. But what will tell you that it's a myeloid blast is only going to be your CD markers. What are the CD markers that will be positive? I told you this 1333 will surely be positive in any myeloid blast. You need not tell about that at all. But apart from that, they will have CD117 also will be positive. CD117 also will be positive. At the same time, they can have CD34 positive or negative and HLA-DR positive or negative. But I still believe that this 1333 tends to remain the most important of all the CD markers for this myeloid lineage. Clear? So this is all about your FAB M0 or AML M0. Then let us move to AML M1. So what do you mean by AML M1 is with minimal maturation. That's what I mean by AML M1. So what do you mean by minimal maturation? What do you mean by minimal maturation? Idea of minimal maturation, the word minimal means there will be less than 10% maturation beyond a myeloblast. Less than 10% maturation beyond a myeloblast. As simple as that. Less than 10% maturation beyond a myeloblast. So this is what we refer to as with minimal maturation. So if you ask me, you can see a bit of oil rods here going on. So which means this will be a little MPO positive. So when you call positive or negative, positive means more than 3% of the blast will stain for MPO positivity, and if it's less than 3%, we call MPO negative. If it's more than 3% staining is there, then it's called MPO positivity. But the percentage will increase with as you move down up to M3, and again from M4 it starts decreasing. Clear? So MPO positive, Sudan black will be positive, and non-specific esterase negative, and PAS is going to be negative. So this is going to be staining, and definitely MP1 Sudan black positivity with, you can see this minimal oil rods in few blasts. Oil rods will, which means oil rods will be seen in approximately 50% of the blasts. Almost half of the blast is going to show oil rods. That's why he told only 2 blasts here I have shown. In that one is showing oil rods, one is not showing, which means it's equivalent to 50% of the blast showing oil rods. Clear? Just to make you understand. Okay, so is there any recurrent cytogenetic abnormalities that can be positive? So cytogenetics, because first you tell the morphology, then you tell the staining and the iron rods, then finally I am going to tell about the cytogenetics. So cytogenetic abnormalities, yes, for sure, you can see a lot of cytogenetic abnormalities here. The 2 important things are the trisomy 8, number 1, and Philadelphia chromosome positivity, that is T822, that is translocation 821. Sorry, T922. So very sorry for that. So translocation 922. So this is Philadelphia chromosome, the classic Philadelphia chromosome. Remember this T922 translocation. If you ask me, sir, I was oriented towards CML. The moment you tell Philadelphia chromosome, that why you telling in AML? Actually, it's not like that. This Philadelphia chromosome translocation can be seen in any malignancy. It can be seen in CML, it can be seen in ALL also, it can be seen in AML also, but the frequency of the change is going to completely vary. So the Philadelphia chromosome positivity in CML has to be 100%, which means without the Philadelphia chromosome positivity, you cannot diagnose CML. That's the current trend. It is not a CML if you have Philadelphia chromosome negative. If it's Philadelphia chromosome positive, it can be anything, but like CML should have 100% Philadelphia chromosome positivity. ALL, as 10 to 30% of the times you might get this Philadelphia chromosome positivity. In AML, you are going to get only 1 to 2% of the times this Philadelphia chromosome positivity, but the frequency will vary, the maximum being with CML and least being the AML. Clear? So this is where you are going to get the Philadelphia chromosome positivity in FAB M1, that is AML M1. Apart from that, what do you mean by FAB M2? So that is called AML M2. When the moment I call M2, which means it is with maturation. That is AML with maturation, which means what maturation? They are going to go for granulocytic maturation. As the name suggests, you can tell there are some granules, in fact a lot of granules you can see, which means these are AML with maturation. But by definition you have to tell at least more than 10% of the blast should have maturation beyond your myeloblastic stage. So I told you this is the only thing that differentiates between M1 and M2. M1 is less than 10% maturation beyond myeloblast, whereas M2 is more than 10% maturation beyond the myeloblast. And you can see a lot of granular cytoplasm. And if you move for the staining process, so in the staining process, your myeloperoxidase definitely could be strongly positive, at least like 50% plus will stain positive, and Sudan black again will be strongly positive, 50% plus stain. And PAS obviously negative, and non-specific esterase is going to be negative. There is no doubt, which we have discussed already. And coming to the iron rods, yes, majority of them will show the iron rods. Iron rods will be strongly positive. Almost 70% will show iron rods here. Clear? So definitely it's a M2 blast. So is there any recurrent cytogenetic abnormalities? One classic cytogenetic abnormality is there. You know that cytogenetics wise, if I want to discuss this M2, cytogenetic wise, cytogenetics classic, two cytogenic abnormalities in fact. One is called T821. So this is what I was discussing with Philadelphia last time. Sorry for that. So T821. So very, very important and a signature change associated with an AML. So whenever you have a T821 translocation, what are the genes that are going to be juxtaposed? That's called RUNX1 and RUNX1T1. These are the two genes that are going to mix with each other, and this is the translocation that catalytically leads to AML-M2. And second one, you have something called T69 translocation, which is also really important to understand. And these are the two important classic cytogenic change. And one important characteristic feature of this AML-M2, you know that they are going to have increased risk of your chloromas and leukemia cutis. Chloromas and leukemia cutis, even though not as much as that of M4 and M5, but they are going to definitely have high risk of leukemia cutis, especially this T821 translocation is going to increase the risk of chloromas and leukemia cutis. You have to be very, very careful about that. And one more interesting point about this M2 AML is, it is the most common variety among the AML subtypes. So among the FAB classification, if somebody asks you which is the most common, you have to answer it is AML M2. M2 type is the most common of all the acute myelogenous leukemias. I hope you got it. Clear? And morphology wise, there is not much different except for the changes in all these things. And CD markers, definitely, there's no doubt CD13 and 33 will be positive, and similarly your HLA-DR may be positive, HLA-CD34 also may be positive, but it all varies. But CD13, 33 will be positive here, which is the myeloid blast. Here also I didn't tell that, but definitely here also CD13, 33 will be positive. So let us put in a nutshell how we differentiate between this M0 and M1. We're going to differentiate based on the CD markers only. How to differentiate between M1 versus M2, it's all about how many blasts are having maturation. Less than 10% maturation beyond myeloblast, it's going towards M1, and more than 10% maturation beyond myeloblast, it's going to be M2. And let us move on to a classic variety that's called FAB-M3. FAB-M3 is also called as acute promyelocytic leukemia, where the only promyelocytes will proliferate. The main reason, you have to know the cytogenetics, why they don't differentiate beyond promyelocytes, but before that, let us see the characteristic features of these promyelocytes. These promyelocytes, first one, the nucleus appears to be rounded in configuration, or it can be bilobed, rounded in configuration, or it can be bilobed in configuration, or it can be cleaved also, folded or bilobed configuration. So that's what is going to happen. At the same time, you can see one more thing here. What you can see is, you can see a plentiful of granules, hypergranular cytoplasm. You can see it's less basophilic, but it's going to have a very, very hypergranular cytoplasm. And you can see plentiful of iron rods. This is I told you this is the one AML where you are going to see the maximum iron rods in this particular AML only. Maximal iron rods, maximal MPO staining, maximal Sudan black staining, everything is going to be with this. And you can see this kind of multiple iron rods, the cells, the promyelocytic cells that are having multiple iron rods like this. We refer to as something called fagot cells. We don't call maggot here because it's not good to call maggot. So that's why we call by a new name called fagot cells, because these iron rods are so multiple inside a promyelocyte that they look like there is some maggot proliferation within the cytoplasm. That's why we are going to call it as fagot cells, very high level of iron rods. And if you take the immunohistochemistry, they are definitely going to be MPO positive very strongly, 100%, the strongest MPO positivity, strongest Sudan black positivity, and obviously it's past negative and non-specific esterase negative. So these are some of the important things according to acute promyelocytic leukemia. And there is some entity called a microgranular variant. So microgranular variant is something you might confuse with the monocytic lineage with AML M4 and M5, but it's going to show the same picture as what you see, the cytochemistry picture and all. But you have to be careful about the microgranular variant, which might not show, because iron rods will be very small and it look like granules, and you might confuse with the M4 and M5 myelomonocytic lineage. So be very careful. There's something called microgranular variant of M3, but in exams it's not important. Suppose if you want to know what are the cytogenetics are the ones that are really important. There are two cytogenetics that you have to know. One is called your classic APML translocation, that is T1517, translocation 1517, and second one you have something called T11 and 17. This 1517 is classic, and this is what is going to be seen in majority of the adult population. Majority of the adults are going to have this T1570 only. Even in children, T1517 is very common, but T1117 you can see in some children. I am not telling most common in children is T1117. Even in children it's T1517 only, but T1517 is usually seen in children. So this translocation is really important. It's a signature translocation of APML. With this, I told you this 821 in M2. It's a signature translocation of M2. Similarly, this 1517 is a signature translocation of M3, AML M3, pyromyelocytic leukemia. And what is going to be the significance of this 1517? Because if you ask me T15 and 17, this 15 carries something called PML gene, and this 17 carries an important gene called RARA gene, that's called retinoic acid receptor alpha. There will be something called fusion of this PML RARA gene. So there will be fusion of PML along with RARA. That will result in disruption of RARA. That will result in RARA disruption. RARA disruption. Retinoic acid receptor alpha disruption. So why disruption of retinoic acid receptor alpha is very important? I told you in the previous slide itself, if you have a promyelocyte, and I told you, and it's going to differentiate into neutrophils, eosinophils and basophils. For differentiating into neutrophils, eosinophils and basophils, you need this retinoic acid receptor alpha. If RARA is not there, if retinoic acid receptor alpha is not there, is disrupted, then there will be a block at this, and that is the reason why promyelocytes are increasing and it's not going to differentiate any further. That is the reason. So that's why it is happening. That's why you are getting this acute promyelocytic leukemia. That is the reason why this T15 translocation is a signature translocation for APL, that is acute promyelocytic leukemia. So this PML RARA fusion you have to understand, and obviously they are going to stain positively for CD13 and 33. There is no doubt about that. And typically this is the point where your HLA-DR completely becomes negative and CD34 completely becomes negative. Till AML M2 I told you CD34 may be positive or negative and HLA-DR may be positive or negative, but here it is both are negative for sure. But again they are going to express their myeloid markers. With all the cytochemistry and cytogenetic changes, you are going to definitely pick up your APL very easily. And very important point about that is, like I told you, M2 has a little bit increased chance of getting chloromas and leukemia cutis. At the same time, it's the most common type of AML. Similarly, there is one specialty clinically for this M3 that almost 10% of the cases going to present with DAC. First presentation itself will be with DAC only. So if they ask you AML that presents with DAC, you have to go for M3, that is acute promyelocytic leukemia. So the next type of AML, what we are going to see on AML M4. In AML M4, you can see that the definition wise, if you see, it is something called a myelomonocytic leukemia. A myelomonocytic leukemia. So if I am going to call it as a myelomonocytic leukemia, what will be the definition? There is going to be at least more than 20% granulocytic differentiation. There is going to be at least 20% of granulocytic differentiation. And there will be at least 20%, more than 20% of monocytic differentiation also, more towards monocytic precursors. Monocytic differentiation also will be there. So since they are having 20% granulocytic differentiation, definitely they will be staining PAS positive. They will be staining myeloperoxidase positive, and they will be staining for Sudan black positive. Surely, because at least 20% is granulocytic differentiation. If granulocytic means surely this must be positive. And similarly, since they are more than 20% monocytic differentiation also there, and NSE is going to be positive. That's non-specific esterase also is going to be positive for sure. At the same time, again, since because they are having granulocyte differentiation, a few IR rods also may be seen. Variable number, not like what you see in M3, but still you might get a variable number of IR rods here also. So these are some of the important things that you have to know. At the same time, as I told you for M2, these patients also have increased risk of developing chloromas and leukemia cutis. Increased risk of developing chloromas and leukemia cutis. Clear? So in AML, M4 as well. And if you ask me what are the CD markers that will be positive, definitely they will be CD13 and 33 positive because they have a lot of myeloid differentiation. At the same time, typically they will have CD11B and 14 positivity, and this is what is going to be the most important, the CD11B and 14 positivity, because this is the one that suggests it's a monocytic differentiation as well. Even though I will give a summary at the end, but still you have to be very clear about that. This is what is going to give you the monocytic differentiation. Do you understand? Yes. So now we are moving on to the cytogenetics. What are the important cytogenetic abnormalities that you get with this AML M4? The very, very important cytogenetic changes in version 16. And the second cytogenetic change is it's a deletion 16Q. It's a 16Q deletion. But as far as I know, the most important for exams, I believe, is the inversion 16. These are all about your M4, this thing, but why I have written something called E0 here? Any idea why I have written E0 or EO, eosinophil? So why I have written eosinophil is because there is a variant called eosinophilic variant where you will have AML M4, yes, but at the same time patient will also have something called bone marrow eosinophilia. Bone marrow eosinophilia will be there. This is what we call M4EO variant. So here where you can see, this is a variant actually that I want to show two things in the same picture, that's why. So this you see a lot of eosinophilic staining here, and this is nothing but bone marrow eosinophilia. Actually the slide which I have shown is nothing, picture which I have shown is the variant, that is M4EO variant, that is M4 with eosinophilia, bone marrow eosinophilia. And the characteristic cytogenetic change that is associated with this M4E0 variant is again inversion 16, and you have something called translocation 16 and 16. So this inversion 16 and translocation 16-16 is one of the very important things, and this 16-16 is actually a signature genetic change according to WHO classification. It's a very important signature change that is seen with AML M4 with eosinophilia variant, bone marrow eosinophilia. Clear? So this is a very important thing. At the same time, M4 also shows one important thing. They have increased levels of serum lysozyme, increased serum lysozyme levels. At the same time, they also tend to have increased serum muraminidase levels. Muraminidase and lysozyme. This is the final nail in the coffin. That's it. So with this, we can move on to the AML M5. Don't worry about that. I'll give a nutshell in the final summary after this, completing all these images. You have AML M5 where you are going to have predominantly your monocytic differentiation. That's why it's called monocytic leukemia, where your more than 80% will be monocytes and their precursors. That's why monocytic differentiation, and less than 20% will be granulocytic differentiation in this. That is the definition according to FAB. Here you can see more than 20% will have granulocytic differentiation, but here you can see only less than 20% will have granulocytic differentiation. This is what we refer to as something called AML M5. And as I told you, since it's predominantly monocytic differentiation, a lot of cells are going to be strongly positive. In fact, the most strongest NSC positivity comes from this particular AML only. And some are granulocytic differentiation are there. So, which means it's not enough to cause Sudan black positivity. I can write Sudan black negative and I can write myeloperoxidase negative, and you are not going to get IR rods as well. And since it's predominantly only monocytic differentiation, they are going to be CD11B and 14 positivity. Obviously, they will be CD13 and 33 positivity because they are myeloid lineage. At the same time, the most important is going to be the CD11B and 14 positivity. And see the number of monocytes. If it's more than 80% with CD11B and 14 positivity, you can tell it is definitely your AML M5. And remember, they will be negative for all this myeloid and granulocytic differentiation, and they will be positive only for non-specific esterase. Important, but the most important is this CD11B and 14 positivity here. 13 and 33 is variable, but still I can write positive because some myeloid differentiation will still be there. Okay, So, and one again important thing is this M5 is also going to show high level of lysozyme and murine levels, like because of the monocytic differentiation, high lysozyme and murine levels. At the same time, these patients will show a very characteristic cytogenetic change, that is deletion of 11q, and you can have something called translocation 9-11. It's very important actually. Then you have translocation of 11 and 19. Of all these three, I will feel this 11-9 is the most important one, because this is going to have something called MLL translocations. That's called MLL T3 and MLL translocations will be there. So that is what you're going to see in this particular type of leukemia, monocytic. Suppose if you have more than 80% monoblasts, there is two types are there in this itself. Sometimes more than 80% of monoblasts, we call this monoblastic leukemia, or if you have more than 80% of pro-monocytes, we are going to call it as monocytic leukemia. But remember, this is acute monocytic leukemia only as a whole, but there are two variants are there. In that more than 80% monoblasts only are there, you're going to call it as monoblastic leukemia, and if it's more than 80% are there, pro-monocytes are there, then we are going to call it as monocytic leukemia. So these are some of the two variants, and this is what is very important to understand. So this is AML M5. And you can see very clearly this is what we called as non-specific esterase positivity, and you are going to get a similar image in exam like this. And let us move on to AML M6 to make it less messy. I can draw here, and this is nothing but an acute erythroid or erythroblastic leukemia, or erythroblastic or erythroid leukemia, where the precursor cell which is going to have a blastic transformation is the pro-erythroblast, or simply you can even call it as a erythroblast. This is the cell of origin for this blast, clear, from which is going to, because this is not going to differentiate any further. So how will you identify a blast? You can see erythroblast. This is a typical example of how an erythroblast will look like. So how it's going to look like, point number one, these erythroblasts are going to be multinucleated. You can see that in this, I told you it's a multinucleated one. And second one, these are going to be vacuolated, and you can see there are definite vacuoles. And number three, they will also have this characteristic megaloblastoid change. Megaloblastoid change with maybe some cytoplasmic projections, but this is the vacuole. You can see the multinucleated cell with a lot of megaloblastic changes. So this is how typically you're going to describe your erythroblast, and plus or minus they might even have a cytoplasmic budding. Cytoplasmic budding. And very important thing to understand is, at least usually in a characteristic erythroblastic leukemia, your two cell lines will be abnormal. Two lineages will be abnormal. Of course, the most important lineage that will be abnormal, more than 50%, you will have erythroid precursors. Erythroid precursors will be there. This is the first lineage that is abnormal. You will be seeing erythroid precursors amounting up to 50% or more. At the same time, you will also be seeing at least 20% of the blasts that are showing myeloid component, or you can tell a non-erythroid component. Non-erythroid means a classic myeloid differentiation towards the granulocytes or monocytes. So non-erythroid differentiation will be there. Non-erythroid cells also will be seen. The blast will be made of non-erythroid cells. So this is very important. So that is the one that makes this a very important and interesting one. So 50% erythroid. So what are the characteristics of erythroid lineage? Definitely they will be strongly pass positive, all these things, and they will show like fine block-like positivity. At the same time, these blasts will be CD13 and 33 negative, definitely, but they will be still positive for CD71 and 235A. If you want to know what is CD71, this is nothing but a transferrin receptor, and if you want to know what is CD235A, this is nothing but a glycophorin C or glycophorin A. So this is what glycophorin A. So this is what we call it as 235A. So this is definitely will be positive. And if you ask me, what you will see in this non-erythroid cells, these are typical myeloblastic differentiation towards granulocytes. So they will have your MPO and Sudan black positivity, and they will be positive definitely for CD13 and 33 positive. So surely. So these are all some of the characteristics, which means always it will be a mixture of both these things. This is the commonest form. But there's another variant here of acute erythroblastic leukemia that is called a pure erythroid leukemia. Pure erythroid means 100% every blast will be of erythroid precursor and pro-erythroblast only. So which means in this condition, it will be strongly and highest pass positivity here, and it will be like fine blocks. and patient will be CD235A and CD71 positive. But remember, they will be typically MPO negative and they will be Sudan black negative, and they will also be negative for CD13 and 33 negative. So this is very important because it's a pure erythroid without any mixing with the myeloid component. So that is the reason why you might get a like these two only positive and this might be negative. This is a pure erythroid, but commonly this doesn't happen. This only does happen. In the beginning in the table I would have told you CD, like your Sudan black and MPO is negative in this erythroid. That is yes, but there are some myeloid mixing is there here, non-erythroid cells are there. That is the reason here I have written MPO positive and SB positive. But for classic cases, for if they ask you erythroblastic leukemia, the most important thing is the past positivity and not the MPO or Sudan black positivity. You can remember as negative only because erythroblast typical that in blasts in erythroblastic leukemia that is coming from the erythroid lineage are not going to have any MPO or Sudan black positivity. Very important to understand. So these are some of the important things that you have to understand. And cytogenetics wise, there is not much important here. There is no much important cytogenetics here. And you can see this is a characteristic past positivity in this image. You can see this block-like positivity of past. You can see here. This is what we call block-like positivity. And finally, we can go to AML of M7 type. In M7, what you can see is this is nothing but megakaryoblast leukemia or megakaryocytic leukemia. It's a megakaryoblast leukemia where the precursor cell or the blast origin of these blasts is from the megakaryoblast. How to identify this megakaryoblast? This is typical example. You are going to have this characteristic cytoplasmic projections or blebs. These are called as cytoplasmic blebs. This is the one that's going to tell you it's a megakaryoblast leukemia. You can see in the peripheral smear also, actually, not only in the bone marrow. You can see these things in the peripheral smear. And very importantly, this megakaryoblast is going to produce very high level of PDGF and probably a TGF beta, but the most important is the PDGF here. So what is the importance of PDGF secretion here? They are going to produce rapid bone marrow fibrosis because PDGF is a very, very, very important fibrosing agent. They are going to produce rapid bone marrow fibrosis, which means you are going to get only a dry tap on aspiration. So you have to do a bone marrow biopsy. Dry tap, you don't get anything on aspiration, so go for a bone marrow biopsy instead. And what are the things that you're going to see here? Cytochemical stains. Number one, highly variable. First of all, you have to know the cytochemistry is highly variable. Typically speaking, MPO must be negative, Sudan black must be negative, NSC may be positive or negative, but for exam's sake, you can remember it's negative, and PAS variable. It can be, again, it can be positive or negative. Extent of positivity is highly variable. So it's very variable staining. The cytochemistry, it's very difficult to confirm it's a megakaryocytic leukemia. At the same time, to add on to the confusion, it can be PPO positive, which means it's a platelet peroxidase can be positive. We don't know. That's why it's very, very confusing. So remember, at the same time, there's going to be very high risk of developing very high risk of AML in patients who are suffering from Down syndrome. Very, very important point. They might give a history of Down syndrome in exam, and the patient coming with pancytopenia and peripheral smear is showing blast, and what is the type of AML? Your answer must be AML M7. Clear? Alright, cool. And cytogenetics wise, there are two cytogens that are very important. I believe this 122 is the most important because it's seen in infants, and second one, you have something called deletion 3q that is usually seen in adults. So I believe that this is the most important translocation that you have to know. Clear? So these are things about your M7 and CD markers. Sorry for that. CD markers I didn't tell you. The CD markers 41 and 61 positivity most important. CD 13 and 33 is variable. That is not that important, but 41 and 61 typical megakaryocyte related CD markers. So that's why it's important. And it can be GP2B3A positivity, but that is not important for me. GP2B3A positivity, but if you give, they don't give an exam, because if they give you that, you can find out it's definitely megakaryoblast. And von Willebrand factor positive. These blasts may be von Willebrand factor positive. These two in exam they won't give because you will be easily answering. That's why. So CD41, 61 is what we have to remember. So this is a nutshell. Everything I have told you about this FAB classification and the AML. But let us see as a nutshell. In the nutshell, you have to see what is the cytochemical staining that different things give you positivity. And you can see the CD markers that will be positive, and you can see what are the comments. Some comments we can see easily. I'm going to construct on spot. I'm constructing the table right now on spot. So what is going to happen? So let us see in M0, what are the staining you're going to see? You're going to see no staining, none of the stains will be positive. CD markers only 1333 will be positive. In comments, it's completely undifferentiated. You're not going to get anything out of it. Only with this I'm going to develop, going to understand it's a AML M0 type. AML M1 staining will be positive. Typically what staining? Sudan black and myeloperoxidase will be positive, and definitely they will be 13 and 33 positive. Comments again, like nothing, so you don't get much about it. And even though you have certain cytogenetics, maybe Philadelphia chromosome positivity, but not that important here. So in M2, staining will be definitely positive, in the sense like Sudan black and MPO, I can write one more plus also because it can be a little bit even more positive, and definitely 13 and 33 strongly positive, and very important signature translocation is 8 and 21. And these patients are having high risk of chloromas and leukemia cutis, and remember this is the most common type of AML. And in a nutshell, you have M3 you have extremely strong positivity for Sudan black and myeloperoxidase. Remember, this Sudan black and myeloperoxidase, you can add one more thing, OIR rods also. Remember, because OIR rods also goes in parallel with your Sudan black and myeloperoxidase positivity. So here is the one where you see maximum Sudan black positivity, maximum MPO positivity, and maximum OIR rod positivity. And definitely they will be 1333 positive, and the most important signature translocation is 1517 PML RARA translocation, which you have seen about in detail already. And you have something called M4. They will be positive, and what stain will be positive? Here it's a little bit confusing. They will be positive for both Sudan black, myeloperoxidase, and they'll also be positive for non-specific estrase, because it's a myelomonocytic leukemia, AMML. And definitely they not only 1333 positive, they will be definitely 11B and 14 positive, surely. So this is what makes sense that this patient is suffering from acute myelomonocytic leukemia. Remember the signature translocation, I will give you inversion 16 and maybe translocation of 1616, both are signature. The 1616 typically is associated with the eosinophilic variant, as we discussed already. Then you have M5, remember the staining will be positive but purely for non-specific estrase only, where it will be definitely negative for myeloperoxidase and Sudan black. And remember here you can see a bit of OIR rods, but here no OIR rods, definitely no OIR rods in M5, and you are not going to see myeloperoxidase or Sudan black positivity. Clear? So again, they can be C 13 and 33 positive, but definitely they will be 11B and 14 positive very strongly, and this is what is the key for diagnosing your monocytic leukemia. And signature translocation, if you ask me, only one important thing is the T911 translocation. That is what is the MLL T3 MLL translocation. That's why this is important. MLL is really important for oncology. That's why I'm telling that. And in M6, they will be staining definitely positive, but the stain positivity only will be for pass. And typically in exam, you are going to diagnose by using this 235A and 71 positivity, 71 and 235A positivity. This is what is going to tell you in exam, and there is no characteristic cytogenetic change. And in M7, you are going to have variable staining. We don't know exactly what staining is, but characteristic MPO and Sudan black are negative, but pass variable, NSC variable, and they can be positive for platelet peroxide. That's why I told you variable staining. But most probably in exam, this 41 and 61 positivity is what is going to give you. It's a megakaryoblast differentiation. And signature cytogenetic change, if they want to ask you in exam, they'll ask you T122. Probably they can ask you that cytoplasmic bleb picture in exam, and they can ask you which is the one. And you also have to know this is associated with bone marrow fibrosis because of excessive production of PDGF, and they yield a dry tap, so you have to go for a bone marrow biopsy. And this is also associated with something called a Down syndrome very commonly. Clear? So these are very important. At the same time, I didn't tell you this thing, this M4 and M5 has a very high risk of chloromas and leukemia cutis. And your M3 is going to be associated with the extremely high risk of disseminated intracellular coagulation. So this is a nutshell, very, very important. What are the standard questions in exam you're going to get? So the most common, M2, T821, M2, and you're going to get this T15, 17, M3, DIC, M3, and chloromas and leukemia acute is very high risk with M4, this inversion 16T1616 translocation in M4, and you're going to get this PAS positivity in M6, this bone marrow fibrosis Down syndrome in M7. So these are the important points. Even though I constructed a table, I told you the most important points I have shaded over here. It might not look very prominently now, but I have written everything. You can, retrack it and you can rewind and see once again if you want. But be very, very careful about this. The whatever nutshell I have told, this is really, really important. Whatever I told you for exams. At the end of the exam, only you study this. You get to answer as much as possible. Clear? So now, having been discussed enough on the FAB classification, we can shift our priority and importance towards the WHO classification. How the WHO is going to classify is very simple. The first one, you have something called AML with recurrent genetic abnormalities. AML with recurrent genetic abnormalities. You can imagine any AML that has the characteristic translocations, which I told you already, are the ones, that is everything put under AML with recurrent genetic abnormalities, the typical translocation which I have told you before. Second one, AML with MDS related changes or myelodysplastic syndrome related changes, which means this is called MDS related AML, very important again. Third one, you have something called AML that is associated with treatment with alkylating agents in the past, that's called treatment related AML. So these two are going to have very poor prognosis and very extremely, resistant to treatment, and they're going to have one of the worst cytogenetic changes you will ever see. So these are the two, second and third are very important, MDS related AML and therapy related AML. Usually typically happens after exposure to cyclophosphamide and other alkylating agents. Number 4, AML not otherwise specified, which means it's not coming under any of the classification. And you have something called a myeloid sarcoma that is separate, which AML is associated with your chloromas and extramedullary manifestations. And you have last one that's called myeloid leukemia associated with Down syndrome. Down's syndrome. So these are the 6 varieties you have. In this, these two is going to have an extremely poor prognosis. I didn't tell you one point, this AML M7, the megakaryocytic leukemia that's associated with Down syndrome, M7 especially, is again going to be having a very poor prognosis and very resistant to treatment, M7 type. You have something called cytogenetic classification of AML. Apart from the WHO classification, even though it's based on cytogenetics, you have a separate cytogenetic classification for AML. What are cytogenetic classifications of AML? The first one you can see is those mutations tend to have a favorable cytogenetics, those AML. Intermediate prognosis, and those have adverse, worst prognosis. Cytogenetics has worst prognosis. The favorable one, you have this typical APML, or you're called as APL, which is associated with T1517 translocation. Translocation 15 and 17. Translocation 15 and 17. And number 2, you have a very important translocation 8 and 21. This is RUNX1 T1 and RUNX1 translocation, which I have told you already that happens in AML M2, favorable prognosis. Number 3, you have inversion 16, which is actually CBFP and MOH1 translocation. I'm not going to tell that. Inversion 16. Then you have something called mutated NPM1, but without, there is a mutation called FLT3 ITD mutations. So this is not present, but without FLT3 and ITD translocation. But NPM1 is mutated. Number 5, you have something called biallelic mutation in CEBPA. Biallelic mutation CEBPA. This is a very important thing again. Intermediate prognosis you can call mutated NPM1. Number 1, you have a mutated NPM1 similar to this, but with FLT3 and ITD translocation, with FLT3 and ITD mutation. Number 2, you have T911, which I have told you already, which has MLLT3 mutation, which I have seen in M5 variant, I guess. Already I've shown you this T911. Third one, like in between. So which means there are other cytogenetic changes that will not be put under favorable or unfavorable, will come under in between. This intermediate prognosis. So adverse one, you have something called deletion 5q, very, very, very important, deletion 5q. Second, you have something called deletion 7. Then third one, you have something called T69, translocane 69, and fourth one, you have something called T922. That is Philadelphia chromosome positivity. Remember, Philadelphia chromosome positivity in CML is different, but whereas if it's present in ALL or AML, it's going to have a worse prognosis. Please be very clear about that. In CML, the prognosis is completely different. It's good actually. But in ALL and AML, if you have this Philadelphia chromosome positivity, it's worst. I'll tell you in ALL as well. And number 5, you're going to have this inversion 3. Number 6, you're going to have wild type NPM1. This is a separate type called wild type NPM1. And if you have a FLT3 ITD high mutation, which means it's going to be at a very high level, then you have TP53 mutations, ASXL1. Remember, ASXL1 are associated with myelodysplastic. I already told you MDS related AML is going to have a very poor prognosis. That's why this ASXL1 mutation, these are associated with epigenetics changes like DNA methylation and all these genes. That is the reason this is actually associated with MDS. And if you have a mutation in AML with ASXL1, means it's an MDS related AML. So that's the reason I've told you it's going to have a very poor prognosis. These are the very poor prognostic cytogenetics. In this, if you ask me, exams they will commonly ask this 15, 17 favorable prognosis, 8, 21 M2 related, it's favorable prognosis, inversion 16 again a favorable prognosis, and this FLT3, ITD and NPM1 is going to be coming in all the 3. You can see this comes in all the 3. Suppose if it's NPM1 mutation but without FLT3 and ITD mutation, you are going to have a good prognosis. If NPM1 mutation is there with FLT3 and ITD mutation, you have intermediate prognosis. If it's NPM1 mutation, that's called wild type NPM1 mutation with very high level mutation of FLT3 and ITD, that's going to have a poor prognosis. It can come in all the 3, but be very careful in what you are dealing with. And probably they might be asking this 5q deletion, 69, 922 Philadelphia chromosome, and this ASXL1 and TP53 all are going to be assessed poorest prognosis. In this, the most important is going to the Philadelphia chromosome. Examiner commonly loves that because they will ask you in AML and they will ask you the prognosis. Definitely bad. Philadelphia chromosome positivity. In ALL, bad. CML, good. Be very clear. CML I cannot tell good because 100% all the cases in CML are going to have Philadelphia chromosome. So it's other things that determine the prognosis. I'm not talking about the prognosis with Philadelphia chromosome in case of a CML anyways. Clear? So these are the 3 important things that you have to know. In this, I want to tell you only about this FLT3 ITD mutations. Remember, you have 2 types of FLT3 ITD mutations. FLT3 mutations are there. One is called ITD mutations, that's called internal tandem repeats. That's called internal tandem repeat kind of mutations. Second one is called TKD mutation. This is called tyrosine kinase domain mutations. Tyrosine kinase domain mutations. You have 2 types of mutations of FLT3. One is called ITD mutations and second one is TKD mutations. ITD means internal tandem repeat mutation and TKD means tyrosine kinase domain mutation. In this, which is supposed to be the most common, ITD. This is going to be the most common FLT3 related mutation, that is called internal tandem repeat mutation. This is going to be the most common mutation. Then let us go for the treatment. Treatment of AML. Treatment of AML you can divide into 2. AML without APML, so AML alone, AML except all forms of AML except APML, APL or acute promyelocytic leukemia, or separately you can discuss about APL. Acute promyelocytic leukemia is going to be treated in a very separate way. So what are you going to do this? How are you going to deal with this? AML The first thing, the very important, APL will be treated in a completely different way. So how will you treat this AML is by doing something called induction chemotherapy. In induction chemo, you have something called a standard 7+3 protocol. That's what we follow. Where in the 7 protocol, in the first day 1 to 7, we are going to give continuous infusion of something called cytosine arabinoside. Cytosine arabinoside are otherwise called as Ara-C. So in day 1 to 7, it's a continuous infusion of cytosine arabinoside. It's a very toxic compound. But anyways, the next 3 days, that is days 8 to 10, I am going to give anthracycline bolus. Commonly we use either a liposomal doxorubicin or a daunorubicin, anyone. These are anthracycline drugs. So anthracycline I will be giving as a bolus. Suppose if age is less than 60, I will be giving very, very high dose of daunorubicin or doxorubicin. If age is more than 60, you can give standard dose daunorubicin. Increased dose means it is around 90 milligram per meter square of daunorubicin, and the standard dose means 60 milligram per meter square of daunorubicin. Clear? So this is the standard regime for induction therapy of standard AML cases, but not APL, that is M3 case. Apart from M3 cases, everything can be treated with this protocol. Remember, it's a 7+3 protocol. First 7 days, I'm going to give continuous infusion of your cytosine arabinoside, that's Ara-C, and the remaining 3 days, I'll be giving bolus shots of daunorubicin. This is called 7+3 induction regimen protocol. You have some newer regimens also. Newer regimens, what you can do is, suppose if age is depending on the age, suppose our fitness, see the fitness and age. Remember, fit cases, typically if age is less than 75, we call them as fit, or unfit cases, typically we call them as age more than 75. So for fit cases, you can use your different targeted therapies. For example, if you have a FLT3 ITD or TKD mutation, if the patient is having FLT3 ITD or a TKD mutation, IDB or TKD mutation, in these patients you can use a traditional 7+3 protocol, plus additionally you can add an FLT3 inhibitor. I already told you this FLT3 inhibitor in the basics of WBCs, where I would have told in systemic mastocytosis use a drug called midostaurin. The same thing we are going to use. This is a newer drug, that's an FLT3 inhibitor. You can use in patients who are having FLT3 mutations. Second one, you have something called cord binding factor positive. That's called CEBPA. I told you already, that's called cord binding factor positivity. If this cord binding factor is positive, usually it will be associated with this T821 mutations or inversion 16 mutations. Remember 821, I told you is the most common type of AML you have, that is AML M2, you are going to have this 821 mutations, I told you already. So if it's cord binding factor positive, typically it happens in this 821 and inversion 16 mutations. So in this condition, you can use the traditional 7+3 regimen, plus at the same time you can add something called a gemtuzumab. So what do you mean by gemtuzumab? It is going to be something called a anti-CD33 molecule. Anti-CD33, here it is approved right now, but other AML, it's not yet approved. But the drug, at least you have to know, that is gemtuzumab, it's anti-CD33. And then you have secondary AML, that is treatment related AML or MDS, either MDS related or treatment related AML. So in this condition, usually you are going to add a drug called, you are going to put a regimen called CPX351. So where you are going to use something called liposomal arabinoside, plus you are going to add liposomal doxorubicin or liposomal daunorubicin. So this is what you are going to give. This is called what we refer to as something called CPX351 regime. So these are the things that you have to know. In this, the two drugs that you have to know for sure is this midostaurin and your gemtuzumab. So these are two drugs I would like you to know. Unfit patients, typically we use something called venetoclax. This is a newer regimens according to the trials I am telling you. This is venetoclax. Already we discussed venetoclax. It's a BCL2 blocker. plus any one of the two things you can add. What are the two things you can add? Either you can add a hypomethylating agents like azacitidine, which is a DNA methylase inhibitor, or you can add a low dose Ara-C, cytosine arabinocyte. So this is a modern regime. So traditionally you have 7+3 regimen, or you can use this modern regime also, especially if the patient is unfit. They might not be tolerating that continuous infusion of Ara-C for 7 days and 3 days of daunorubicin. In those patients you can try venetoclax with your hypomethylating agents, DNA methylase inhibitors like azacitidine, which I have discussed already, or you can use an alternative low dose cytosine arabinocyte. So these are the regimens that you can use depending on the fitness. So then once you finish the induction regimen, then you have something called a consolidation therapy. Number 2, you are going to have something called consolidation therapy. So consolidation therapy depends on the risk. So whether it's a favorable risk or whether it's a high risk. Whether it's a high risk patient. So if it's a favorable risk patient, then you can use something called a HiDAC. That's called a high dose cytosine arabinocyte. That's what we prefer. If it's a intermediate or poor risk patient, it's better to go for allogenic stem cell transplant. While you are giving your chemotherapy itself, you can take the patient for allogenic stem cell transplant, and this all should have been planned before starting the therapy itself, the moment you do the cytogenetics during diagnostic phase, not after starting the treatment. You have to plan for allogenic stem cell transplant if it's a high risk or poor risk. So when you start the consolidation treatment has to be started once the patient enters something called a complete remission. After complete remission only, I will be starting consolidation treatment. So what are the definitions of complete remission? You have something called morphological definitions of complete remission. Then you have something called cytogenetic definitions of complete remission. Then you have molecular definition of complete remission. So in that, what is morphological definition of complete remission? If you have a absolute neutrophil count of more than 100,000, then it goes towards a morphological complete remission. Then you have a platelet of more than 1 lakh. That is again an example of a morphological complete remission. Then you have no extramedullary disease. Extramedullary disease plus less than 5% blasts in the bone marrow, plus patient should not have any oil rods if they are present. So this is what we refer to as something called a morphological complete remission. And cytogenetic complete remission means patient should have normal cytogenetics, and molecular complete remission means patients should have normal molecular markers or negative molecular markers. Negative molecular markers. Cytogenetics you are going to analyze by FISH, and molecular markers you can analyze by flow cytometry or sometimes by IHC. Morphologic, simple smear and bone marrow examination is enough. So this is how you assess something called complete remission. In this definition is what I would like you to know, because this might be important for exams where the ANC, absolute neutrophil count more than 1000, platelets more than 1 lakh, or blast less than 5% in the marrow with no iron rods and no extramedullary disease. So this is the definition of a morphological complete remission. Suppose if the disease is having refractoriness, if the disease is not getting cured, or if the disease is going for relapse disease. The reason for refractory relapse disease is because, like cancer is something, it's also evolving over time. It's not that it's going to be constant over time, even though they express the molecular markers of where it started throughout the end of the course, but new mutations tend to accumulate over time. So initially you might not see a mutation. For a best example, TP53 and all, where later on new mutations will keep accumulating as the cancer grows and it also evolves, and these new mutations are going to make the cancer more and more aggressive, or sometimes even less aggressive. That's very rare, but it actually makes the cancer more and more aggressive over time and refractory to therapy. So in this condition also, the cancer, this blast might acquire new and new mutations over time, which might make the blast more and more aggressive, and that is the reason why you get a relapse or refractory. This is due to clonal evolution of the mutations that is present in the blast. So this is also, there is something called that also is there, which you have to know. So for example, if the patient is evolving with FLT3 or ITD and TKD mutation, remember in this condition you cannot use midostaurin because it's a relapse disease. So this must be a very severe and wild type mutation. So in this condition you have to go for your second generation FLTD3 and ITD inhibitors. Like for example, you have something called giltertinib, or then you have something called a quizartinib. So these are currently approved for treatment of AML, relapsed or refractory AML, but I told you midostaurin in the beginning. So this FLTD3 ITD inhibitors itself, there are two types are there. One is called type 1 inhibitors and second one is called type 2 inhibitors. Type 1 inhibitors and type 2 inhibitors. Remember, type 1 inhibitors, they are active against ITD as well as TKD mutations. They are active. But remember, type 2 will will be active only against ITD mutations, but they won't be working for TKD mutations. What are the drugs that are effective? One is called sunitinib. These drugs you have heard already, but here also it's effective. Second one is midostaurin, which you have seen already. Midostaurin, seen already in systemic mastocytosis in initial phases of the patient is age less than 75, initial disease. In induction regimen, you can add this if you want, along with the traditional 7+3 regime, if the patient is having FLT3 ITD mutation. Then third one you have something called lestortinib. Then you have something called giltertinib. Then you have something called your crinolanib. So in this I told you this giltertinib is going to be the second generation FLT3 inhibitor. That's why we are using relapse disease. And crinolanib is also going to be a second generation FLT3 inhibitor, but we are not using right now crinolanib. The only thing that is approved for use in AML as of now is the giltertinib for refractory and relapse disease. For ITD mutations only, you can use sorafenib, but that is not approved for this purpose, but even though it's a FLT3 inhibitor as well. Then you have something called ponatinib, which is used for CML T315I mutations, which we'll discuss subsequently, but here we don't use for this purpose. And third one is quizartinib. Yes, we use for this purpose. In this, the only second generation FLT3 inhibitor is quizartinib, which is again used for relapse disease. So what is approved is this and this. The crinolanib is not yet approved for treatment in AML, even though it's a second generation FLT3 inhibitor. These are the FLT3 inhibitors which you might be needing to know for exams. And in relapsed or refractory disease, there might be another mutation that might be accumulating in the blast, which is very difficult to treat. It becomes really difficult to treat. That is called IDH1 mutation. IDH1 mutation, and second one is called IDH2 mutation. IDH2 mutation. Remember, there are two drugs that are very important. One is called ivosidenib. This is effective only for IDH1 mutation. And there is another drug called enasidenib, which blocks both IDH1 as well as IDH2 mutations. You have enasidenib and you have ivosidenib. Ivosidenib is going to be active only for IDH1, whereas enasidenib is going to be active against both IDH1 as well as this IDH2 mutations. Then a lot of other chemotherapy regimens are there. You have something called CLAM regime, where you can add clofirapin. Then you have MEC regime. A lot of regimes are currently available. You have FLAG regime also. I'm not going to discuss about all those things. These are different regimes under pipeline, and some of which is approved as well, which is in trial, some of these things which are very effective that we are seeing. But anyways, so these are the important drugs that you have to know that is approved for this AML induction therapy. But finally, you have something called a pro-myelocytic leukemia, which we have not seen. This APL treatment separately is there, which you have not seen yet, but it's actually, trust me, very simple compared to your other AML treatments. APL, acute promyelocytic leukemia, you are going to use typically something called ATRA, that's called all-trans retinoic acid, and second drug that you can use is called arsenic trioxide, that's called ATO. That's called arsenic trioxide. In this, ATRA is considered as the gold standard for treatment of APL. It's called gold standard for treatment of APL, acute promyelocytic leukemia. That's called all-trans retinoic acid. Because it's very clear, PML results from your PML RARA fusion, retinoic acid receptor alpha fusion, where it disrupts this fusion, that is 15-17 translocation. This fuses these two PML and RARA, where RARA function is disrupted. I told you the RARA function already. A pro-myelocyte has to differentiate into a neutrophil, into differentiate into an eosinophil, and it has differentiate into a basophil. And for all these three things, you need this retinoic acid receptor alpha. Since it's disrupted here, instead of this, that's the reason why the promyelocytes are increasing in numbers here. Like the good thing about this ATRA is the moment you add this all trans retinoic acid, like it clears off this RARA problem, and immediately all the promyelocytes will start differentiating into neutrophils, eosinophils, and basophils as well. So that is the reason why you are stopping the block, and you are removing the block, and you are making the promyelocytes differentiate into respective groups, and that is the reason how you can cure this leukemia. Remember, there is also one problem that comes along with it. Since a lot of promyelocytes are already accumulating, the moment you give this all trans retinoic acid, the block is removed, and your neutrophil, eosinophil, your basophil counts, all these things are going to increase dramatically, and which might result in a very important side effect of this all trans retinoic acid called a differentiation syndrome. That's called a differentiation syndrome, or otherwise simply you can also call it as a ATRA syndrome or all trans retinoic acid syndrome. What is going to happen in ATRA syndrome is like I told you, suddenly your granulocytes are going to increase. There will be massive boost in the granulocyte. I told you in ATRA, one of the and APL, very important point. I don't know whether I mentioned this point or not. It's a very, very important point in acute promyelocytic leukemia. I think I have forgotten to tell in AML M3. The WBC count tend to be normal or only slightly elevated. This is one of the gold standard points that you have to know. Usually in AML, the blast count tends to be in lakhs, sometimes even in 50,000s and 70,000s. But in acute promyelocytic leukemia, the blast count tends to be relatively, the promyelocyte count, the WBC count tends to be relatively normal or only slightly elevated. That is because the poor differentiation. That's because of the poor differentiation and block in the promyelocytic pathway. The moment you give ATRA, your granulocytes are going to increase and your WBC count will actually increase too much. From a normal count, it might increase. This sudden increase in the granulocytes causes increased cytokine release. This increased cytokines may result in capillary leak. Because cytokines cause vasodilation, they might result in capillary leak, which itself may result in fever. That is because of cytokines, which might result in shortness of breath, and in chest X-ray you might see infiltrates, which might result in non-cardiogenic pulmonary edema. Then you might see patient themselves develop edema as a whole, and the patient may develop hypotension, and the patient may also develop acute kidney injury. So all these are very important features of ATRA syndrome, and in exam scenario, very commonly these clinical features will be there. Examiner will give you these clinical features. They will give history of APL. At the same time, they will give history of ATRA use. If you see this indicates an ATRA syndrome. That's all. Very simple. And treatment wise, what will you do is you are going to use steroids, dexamethasone, because to suppress the cytokine release. Most important will be the TNF alpha. So dexamethasone you can give 8 or 10 milligram BD. 8 milligram BD is a standard Indian dose, but Western dose is 10 milligram to 16 milligram BD. But whatever, dexamethasone you can use as a steroid. Plus you are going to give supportive care, like you can use diuresis to reduce the edema, or some other inotropic support if there is severe hypotension. Supportive care. Plus you have to stop ATRA temporarily. Remember, very, very important, you have to stop ATRA temporarily. And even few physicians and few hematologists do not even stop the ATRA. They will continue giving ATRA. They will only give dexamethasone, because ATRA is such a beautiful drug for treating this APML or APL, acute promyelocytic leukemia. That's the reason. So standard regime, suppose depending on the risk regime, what you see, it's a non-high risk or high risk. This 15-17 mutation itself is a good prognostic sign, to be honest. Non-high risk versus high risk. Non-high risk means if you have a WBC less than 10,000, or if you have a T15-17, both if you have, then it indicates a non-high risk. In this condition, use ATRA plus arsenic trioxide. You will give a total of 4 cycles. of consolidation. So you will give an initial induction plus you will give 4 cycles of consolidation. That's all, which means you need only this ATRA and ATO, that's it. But if it's a high risk, for example, the presentation WBC is more than 10,000, if the WBC is elevated, or if you don't have this or if you don't have this 15-17 mutation, it's going to be a little bit high risk. It's a poor prognostic sign, where you can use the same regime, that is ATRA and ATO for the same induction consolidation regimen. At the same time, I am also going to add your other chemotherapy drugs like doxorubicin, or I can add even a gemtuzumab, ozogamycin. Gemtuzumab is also called as gemtuzumab ozogamycin, but simply you can remember as gemtuzumab. So this is going to be the regime for high risk patients. I am going to add either a doxorubicin or a gemtuzumab. CD33 we discussed some time back, anti-CD33, gemtuzumab ozogamycin. Okay, so this is how you treat, but the most important that you have to know, these are the 2 things that are gold standard for treatment of, especially the ATRA is the gold standard for treatment of this, your APL, acute promyelocytic leukemia. Clear? So finally, let us put the treatment in the nutshell. As simple as that. If you have AML except APL, as usual, AML except acute promyelocytic leukemia, you are going to use standard chemo induction regimen and consolidation regime. Induction to consolidation, once the patient achieves a complete remission, you are going to shift to consolidation. In induction regime, you are going to use the standard 7+3 protocol. Plus or minus, you can add your FLT3 inhibitor like midostaurin, as I told you, in this regime, or you can use some other drugs also. But in consolidation regime, you are going to use, plus or minus you can use gemtuzumab, ozogamycin, which is an anti-CD33 molecule. In the consolidation regime, I am cautiously going to use something called high dose cytosine arabinoside, that's what I am going to use, or I can even use a allogenic hematopoietic stem cell transplant, any one, depending on the risk. Low risk means I can go for high dose cytosine arabinoside, or high risk means you can use allogenic hematopoietic stem cell transplant. Remember, 7+3 means for the first 7 days I will be using continuous infusion of cytosine arabinoside, and the remaining 3 days I will be using liposomal doxorubicin, or simply doxorubicin or daunorubicin. Suppose if you don't get the complete remission, or after using the consolidation you get a relapse. So this is, for example, you call a relapse after the consolidation regime, or if your complete remission is not at all achieved, that's called a failed regime, fails, or this is what we call the refractory disease. In those conditions you can use other drugs like second generation FLT3 inhibitors, like you have your gilteritinib, and you can use like quizartinib and all these things, gilteritinib and quizartinib, or you can use your IDH inhibitors, which I have told you have something called ivosidenib and you have something called enosidenib. So all these things I have told you, enasidenib and ivosidenib, these drugs you can use. These are alternative drugs you can use for second. Remember, if it's going to be in APL, in exam you remember only combination of ATRA and ATO, this is what I am going to use, and be aware of ATRA. The moment you start ATRA, you might starting to develop something called a differentiation syndrome. The important side effect that you have to note for exam is differentiation syndrome. So this is the nutshell of all which I have told you till now. So this is at least, like in exam when you go, do not forget this, at least minimum. So prognosis finally of acute myeloid leukemia. Final say on prognosis of acute myeloid leukemia. Prognosis wise heavily depends on the cytogenetics. That's why hemato-oncology is absolutely of cytogenetics. You have no thing to do about that. You have to know that. Very important. And if like the examiner is little bit like tough, then they might screw you with the cytogenetics. That's why. So the 3 things that determine the prognosis: the age. So whether it's a secondary or primary AML, history of MDS or treatment related AML, or the patient is having a myeloproliferative neoplasm related AML, this is also secondary AML only. So this is going to have a poor prognosis again, and higher age again is going to have a poor prognosis. Then genetics, especially your cytogenetics. Clear? All these things are very important once again. So let us see the important prognostic factors. Let us see the good prognostic factors. Second one, you have to see the intermediate prognostic factors and poor prognostic factors. Cytogenetics, I told you, that's again it's a nutshell. Cytogenetics, good prognostic, I told you T1517 and T821, the signature translocations, and inversion 16, definitely good prognosis. Intermediate, a normal cytogenetic. Clear? Intermediate, poor, definitely deletion 5, I can write just like that, deletion 7, just like that, and TP53 mutations, and complex karyotyping. Complex karyotype means at least more than 3 unrelated abnormalities. Separate genes are affected, at least more than 3 unrelated genetic defects. This is what we call complex cytogenetic changes, and again it's going to have very poor prognosis. And molecular wise, if you see, molecular genetics wise, if you see, you can see this NPM1 mutation and CEBPA, and if it's NPM of again NPM mutation, but remember here it's with FLT, without FLT3 mutation, but here NPM with FLT3, here wild type NPM, wild type NPM with very high level of FLT3 mutation is going to have a very poor prognosis. Remember, in this usually they will have high level of FLT3 mutation, we call them as wild type NPM associated with FLT3 mutation. Clear? Then bone marrow response to treatment, to induction regime. Bone marrow response to treatment. Suppose I told you if you achieve morphological complete remission, that is if it's less than 5% blasts after first course of chemotherapy itself, after induction regime itself. So that's complete remission within first course of induction, because induction regimen can be repeated actually, but after the first course of induction itself you get the complete remission, it's a good prognostic sign. So intermediate don't have anything to do with. So if you have more than 20% blast after the first course, more than 20% blast after the first course of therapy, definitely it indicates a very poor prognosis. Then age wise, if it's a child, good prognosis. Adults less than 60 years, intermediate prognosis. As I told you, any adult more than 60 years, this is going to have a very unfavorable and poor prognosis. Adults more than 60 years. And next, you have the performance status. Performance status, good, bad, fit and unfit patient, as simple as that. That's it. So comorbid status, no comorbid status, lot of comorbidities, again poor prognosis, because for example a patient is having heart failure already, CAD already, and associated heart failure, you cannot give doxorubicin, because doxorubicin, if you give in high dose, they are going to not tolerate, and that limits your chemotherapy. So that's why I'm telling you comorbidities are going to affect, because certain chemotherapies are going to affect your kidney. If the patient is already a kidney patient, you cannot give high dose or full dose of chemotherapy, or you have to take a risk of kidney being damaged, which you have to treat separately with dialysis, and that makes the patient more prone for death. That's the reason why comorbidities is a very important point once again. Then WBC count is less than 1 lakh, less than 10,000 typically, is a very good prognostic. Typically in APML it happens, or it can be more than 1 lakh, definitely it's poor. Intermediate means somewhere 10,000 to 1 lakh, it's intermediate prognosis. Then if it's a secondary AML, yes, no. No means good prognosis, yes means it's going to have a very poor prognosis. I told you the secondary AML due to after MDS or treatment especially, it's going to be very poor. And minimal residual disease in remission. During remission, whether there is any minimal residual disease, there not MRD means minimal residual disease, that can be assessed by flow cytometry actually. So no, yes. What do you mean by yes? At least there is more than 0.1% cancer cells still circulating in the blood. Remember, this small amount of cells and all you cannot detect by your traditional cytometry, traditional cytochemistry or peripheral smear and all. This can be only detected by special techniques, which I will tell you in some time while talking about ALL. But right now, remember, this is going to tell you a very poor prognosis. I mean, not very poor, poor prognosis again, because it's unfavorable. At least some cells, which means anytime they can proliferate and you can result in recurrence of your cancer. So that's why this minimal residual disease is not a good sign. If you cannot see any minimal residual cells circulating in the peripheral smear on the bone marrow, then it's a different deal again. So these are the important prognostic, like things that you have to know. But as far as so many things are there, but anything can be asked. But I believe that this 15, 17, 8, 21, inversion 16 again, like very, very important for exams. And this deletion 5 and deletion 7 complex karyotyping, again they have been asked already. And probably this complete remission, good prognosis, again you have to know. And extremes of age, like more than 60 years, good poor prognosis, and another extreme child as having a good prognosis. And you can go for this minimal residual disease. This also could be an exam question. And secondary AML definitely is a poor prognostic. And all these are very important. As far as I filtered a little bit for you. So all are important, but I filtered from that few points which are really, really going to be important for your exam. So this is what about AML is, things are. Even if you get a single question, the problem with hematology is oncology, especially in hematology, tends to be a little bit tough because of the cytogenetics involved, and that's why many students do skip. But if you really know and really have an interest, it's very easy to remember all these things, and you can actually score much easily than a clinical scenario question, because in hematology they'll give a clinical scenario and they're going to ask only on the cytogenetics most of the time, and maybe they might be asking the treatment, or maybe asking the differentiation syndrome due to ATTRAC kind of thing. A little bit simple, but you have to know an entire bird's view kind of an idea. I've given a bird's view idea about all this classification systems, treatment, and the newer drugs. A lot of newer drugs are there in AML, which I've told you. Advances are there, which also I have mentioned in this. So I think this must be enough. AML we can discuss for another 2 hours as well, but still I don't want to make it more and more complicated. I think this is clear, simple, and as elegant as possible. So with this we can complete the AML and we can move to the next section on acute lymphoblastic leukemia.